All right, Jeff, over to you.
Thank you so much, Erin. Welcome, everybody. It's a pleasure to be here at this LEVERS workshop. My name is Jeff Shaman. I'm a professor at Columbia University who studies and models infectious diseases. I also look at some of the effects of climate on infectious diseases. And we have a panel discussion as part of the larger workshop today, this afternoon, that's going to be addressing scenario modeling, what worked and what didn't during the pandemic. With me to engage in this discussion, I have four distinguished colleagues from various sectors in the infectious disease modeling and public health space. I'm just going to introduce each of them in turn, and then I'm going to start posing some questions and hopefully stay out of the way and not let whatever biases I have creep in. So the first person I'm going to introduce is Dr. Amit Huppert. He is a professor at Tel Aviv University. He has a PhD in mathematical modeling in the area of population dynamics and has been involved in biomathematics and epidemiological modeling for over 20 years. He completed a postdoctoral research stint at Woods Hole in the statistical modeling of climate change, but he's got a broad interest that's developed and moved towards infectious diseases since that postdoc. And much of his work over the last 3 years has been involved in the mathematical and statistical modeling of COVID-19 in Israel. Welcome, Amit. The second person I would like to introduce is Professor Sarah Cobey. Sarah is a professor in the Department of Ecology and Evolution at the University of Chicago. There, her group investigates the coevolution of pathogens and host adaptive immunity using computational models to test hypotheses and to advance theory. In the first 2 years of the COVID-19 pandemic, a group performed scenario modeling and provided regular consultations to the state of Illinois. She also used models to provide input on vaccination strategies and evolutionary impact of dose sparing, including to the WHO. She graduated from Princeton University and obtained her PhD in ecology and evolution from the University of Michigan, and then had an NIH Kirkstein Fellowship at Harvard School of Public Health before becoming a professor at the University of Chicago. Welcome, Sarah. The third person I would like to introduce is Dr. Jason Asher. He is the director of the prediction division at the CDC's newly formed Center for Forecasting and Outbreak Analytics, or CFA. There, he is building a world-class team of modelers and data scientists to provide faster and richer evidence for decision-making during outbreak responses. Prior to joining the CDC this past August, Jason led a team of analysts at Health and Human Services Administration for Strategic Preparedness and Response, ASPR, who were responsible for modeling threats that span the range of chemical, biological, radiological, and nuclear hazards, as well as emerging infectious diseases and pandemic influenza. His work has included cost-benefit analysis and actual and hypothetical countermeasures, clinical trial planning and simulation, and the design of software tools for modeling, analysis, and visualization. He's also developed innovative techniques and tools for both forecasting and scenario-based projection of the spread of infectious diseases, and has applied them in responses including the 2014-16 Ebola outbreak in West Africa, the Zika outbreak in the Americas, and the ongoing SARS-CoV-2 pandemic. Welcome, Jason. And lastly, we have Dr. Celia Quinn. Dr. Quinn is the Deputy Commissioner of the Division of Disease Control at the New York City Department of Health and Mental Hygiene. In this role, she leads New York City's management of and response to a range of infectious diseases, including vaccine-preventable diseases, sexually transmitted infections, HIV, tuberculosis, and other communicable diseases. She also oversees the Public Health Laboratory and the Department of Health and Mental Hygiene's clinical services. Dr. Quinn served as the incident commander of the Health Department's COVID-19 response. She is an alumna of the Mount Sinai School of Medicine, where she also completed a Master of Public Health. After completing her pediatric training in the residency program for social medicine at Montefiore Medical Center, Dr. Quinn joined the Centers for Disease Control and Prevention as an Epidemic Intelligence Service officer. She is currently a CDC field assignee to the New York City Health Department and is a commander in the U.S. Public Health Service. Welcome, Celia. All right, so we are going to run this as a panel discussion, and I'm going to start with some fairly broad questions, and we'll see where it goes from there. I'm going to start off with a very basic question, which is, how did you employ scenario modeling during the pandemic? Celia, I would like to start with you on this. So how did you?
Thank you. Thanks, Jeff. And just thank you and the organizers for including me on this panel. I'm really excited about the discussion we're going to have. So yeah, I'll speak a bit from the New York City Health Department perspective about how we approached this during the pandemic. We definitely collaborated a lot with academic modelers throughout our pandemic response. Some of them include you, but others as well. Some of the really important uses, from my perspective, included using models to do near-term projections to inform resource needs. We also did scenario modeling to understand possible impacts of certain policy decisions that might be under consideration and communicate those to decision makers within the city. And also sometimes use it to inform public communications to help guide or to inform public opinion and behaviors. So I'll just give a couple of examples of those if that would be helpful. So in terms of like near-term projections to inform resource needs, so at the very beginning of the pandemic in late February, early March, we were trying to anticipate what might this initial wave pandemic surge look like. How many hospital beds will we need in New York City? What other resources we might need to support that surge. Later, as we were trying to design a contact tracing program that would be testing and tracing for New York City, we needed to figure out just, like how many people do we need to hire? How many cases can we manage in a week? So we definitely were looking at models to try to predict those kinds of needs. And then in a later phase of the pandemic, thinking about the vaccine rollout, we were modeling vaccine supply and against demand and trying to understand how to do distribution equitably across New York City. We're also trying to look at different kinds of models to anticipate those needs. We used it to look at certain policy decisions and help inform decision makers. And so that included modeling various approaches to reopening in terms of like timeline for reopening different things that had been closed down during the first pandemic wave. And it also informed how we approached school testing strategies during the first year that schools were reopened and how to best utilize testing resources across the New York City's public school system. An example of when we used it for informing public communications was last year as we got through the first year of the vaccine campaign, and as we're about to roll out pediatric vaccines, we used modeling describing the number of lives saved that could be attributable to our vaccine campaign. And that also informed a paper about the return on investment for the vaccination campaign. And that really helped to continue to advocate for the resources we need to keep doing vaccine campaigns and help people understand the need to get vaccinated during that phase of the campaign. And then the last use, which I didn't mention yet, and is one of the ones that I definitely observed a lot during the pandemic, was this, what I call the show your work challenge that we have in public health, where often we had to kind of close the gap between the sort of epidemiologist's intuition about what our surveillance data is telling us about what is likely to happen in the coming weeks and our policymakers' understanding about looking at that same data. So sometimes it was very helpful to have modeling data to kind of close that gap and show, why am I so concerned about this very small number of cases, is because I have a little intuition about what that means for the next few weeks, where that needed to be really put in black and white for people who are less familiar with our surveillance systems, with how public health data is collected and interpreted. So at the very beginning of the first wave, looking at the first few days of hospitalization data that we had for COVID-19, we definitely needed to rely on some modeling to bring that information in an impactful way to decision makers.
Fantastic, Celia. If I can ask some follow-up questions on that. It sounds for that last issue where you had maybe some disagreement as to what was going to happen based on the intuition of epidemiologists versus policymakers, government officials, et cetera. You're really talking about sort of different thinkings on what's going to happen, maybe different mental models as to how the pandemic was going to unfold. And it's in that space, it sounds like having some sort of more numerical approach that's a little more concrete helped close the gap on this. Is that a correct way of thinking about this in that sense?
Yeah, I think so. I feel like that's what I observed.
Did you notice some growth of trust in the modeling over time, or was there sort of an erosion, or did certain actors have resistance that persisted and others came to be informed by it?
Yeah, it's an interesting question because there was as probably many of you recall, a proliferation of different models that emerged over especially that initial phase. And there was such divergence. And I think there's not a lot of, people have a lot of difficulty with uncertainty and kind of understanding how to make decisions in that space. So I'm trying to think of how to best answer your question. I think, there's like a very human impulse to want to choose the answer that makes you feel the best. And so a lot of times, the decision makers might not be even familiar or understand the methods that underlie the scenario modeling, and have a different way of interpreting the, outputs that are coming from different models than our health department did. And so that there certainly were challenges inherent in that. And there, as things progressed, we had a lot of different people competing for attention too, and all using, models to try to justify different positions. I think that was certainly a challenge to navigate. One thing that I am focused on now in the health department is trying to build up our capacity, not to necessarily do a lot of modeling. I think we'll always rely on academics and, hopefully the Center for Forecasting and Analytics as well, to do some of those, especially during emergency responses, but just to try to find ways to help build the capacity of our staff within the health department and leadership within the health department to understand how to best evaluate and use information that's coming from predictive modeling.
Do you think at first there was an overtrust in the models, and then that started to erode as more and more models appeared and they started to say different pictures? So I'm almost envisioning at the beginning you have some people who have one model of idea, maybe it's your epi folks have a certain intuition, and then you have the policymakers who may be in a different space and less convinced. Did seeing a model, even if it was only one, bring them together just simply because it looked authoritative at that point? Or was there, did skepticism come in once there was this divergence of models out there, or is that just a totally wrong narrative I'm painting there?
Trying to remember exactly how things went down in February and March. It's really hard for me to answer that question. I think I'm trying to recall like how divergent some of our different projections were in those early phases. It's always helpful to have something to react to, right? Like regardless of who you are. So I think it was a starting point for conversation, and that was helpful. I think there was a lot of, I was mentioning different reasons why we're using certain models. And so I think there was also, when people are looking at the same model, but using it for different purposes, that opens up another area for conflict and like doubt to kind of get involved. So, and I think that's something that our health department tried to utilize throughout the pandemic in different ways as well. So there's that. I think that, the other example that I think I recall coming up relatively early on was like trying to explain to, our emergency management colleagues, well, okay, this is like not that different from when you look at your hurricane forecast and the lines are all over the map and some of them are going this way, some of them are going that way. And we have to, look at a bunch of different models. And as we get more information, they become more refined. So that analogy was very helpful for explaining to policymakers, like, how do I interpret what I'm looking at here? But it did take a while for us to get to that point. And it was a lot of education for, not just policymakers that we're working with and decision makers, but their staff as well.
Yeah, and that work with uncertainty is certainly a big issue. And in some sense, almost all of us in whatever our field, we work with uncertainty. It's often that when we're confronted with it in other contexts that it becomes a little overwhelming as to what to do. One last question before I hop on to the next panelist. How did you decide which questions to address? Was this just sort of a reactive expediency at the moment? Was this being directed by, let's say, by City Hall in New York City? Was these questions that you built out with a team? How are you deciding what you needed to approach over the next 1 to 4 weeks, let's say, with the modeling that you were leveraging?
Yeah, it's a great question. A lot of the response, was coordinated through City Hall within New York City. So, and certainly to the extent that questions about specific policies were being raised, a lot of that had to come from City Hall because, we only want to test things that are within the realm of possibility. So, so I think that to that extent, yes, that's where those kind of questions were coming from. Some of the more operational types of uses was definitely like more focused on the program level, like, okay, I need to order this much PPE. How many cases am I expecting in this amount of time? So those were more directed from the program side and people involved in it.
And is that something that you think needs to be more regularized, or you think the next time, unfortunately, there's a pandemic or emergency of a large nature, that it's going to have that sort of reactive, interactive flow?
I mean, well, we're still in the process of doing our after action for COVID here in New York City.
You're still hot washing it.
I
Okay, fair enough.
suspect that, we're going to have some findings related to how we utilize those things.
Yeah.
I don't want to speak on behalf of New York City about how we might do that in the future, but yeah, I mean, I think, well, one finding from every after action is that, like, it would be great if we could be more proactive and not be so reactive. So anticipate that might be something that we see.
Fantastic. So I'm going to turn to Sarah next. Sarah, I know you did in my introduction of you, you mentioned the content you provided, talk about working with the state of Illinois. Could you tell us a bit about how you did employ scenario modeling and what you thought was helpful about it and when you thought it was less than satisfactory? Could you talk a bit about that?
Sure. So I led one of the 4 academic groups that was providing regular input to the governor's office and the state public health department. So there was a group from the University of Chicago that I led, another group from Northwestern, another group from Argonne National Lab, and then the 4th was from University of Illinois Urbana-Champaign. And so we met several times a week to compare our scenario models for the state. And this work was coordinated by Civis Analytics that was hired by the governor's office to help synthesize the messaging and results from the academic research groups. So generally, our scenario models attempted to, again, predict dynamics over just the next couple of weeks. We weren't generally trying to predict farther out than a month. And the sorts of things that our models were outputting and that we were carefully comparing across models included census hospital beds, hospital admissions, ICU usage, deaths, and we did that for different regions of the state. And we also, had the opportunity to inject like our own, like additional kind of thoughts about what was going on. And so we developed the habit of always giving them our estimates for the effective reproductive numbers in different areas. And then we performed also a lot of ad hoc analyses similar to what Dr. Quinn was, describing related to contact tracing and things like that. So the models took a lot of different forms. We used at University of Chicago stochastic compartmental models that we fitted to several different types of data. And as I'm sure is true for most of the modelers here, of course, the precise form of the model was changing over time and was constantly adapting to different data streams. There was another group that was using agent-based models, another group that was kind of using more kind of like calibrated, like hybrid types of models. Yeah, so that's the general story.
And did you find was most of the demand in this space of the projections you talked about, the 4-week projections, or did it shift over time to more of that ad hoc analyses, sort of along the lines of what Dr. Quinn was talking about, where can you just help inform what's a reopening strategy or a school opening strategy, or what would happen if we did this policy versus that? Was any of that asked of you?
So I'd say that was asked of us more initially. There was definitely interest in like what would happen once lockdowns were lifted. Again, we were contacted to help inform estimates of the number of people who would be needed to work as contact tracers. But I think there was less of that going on. There was really, I think, just more of a desire for almost like situational awareness. And of course, we academics were interested in looking at, for instance, case ascertainment rates in different areas and different populations. And so we would volunteer that information, again, based on like our own kind of interest in those topics. And there were definitely follow-up, questions. But I would say we were mostly trying to provide, again, these kind of short-term projections that at the time the state public health department, did not really have the resources to be supplying on their own. And you asked in, your first question about what worked and what didn't. And it's hard for me to say. I still am not totally sure exactly how useful our scientific inputs were over time. But, our main goal was to be useful, and we were told at times that what we were doing was useful. But it's hard to know ultimately how it was influencing decision making.
So that actually gets to what was going to be my next question, which was, what was your sense of how the modeling was used? But from what you're saying, it sounds like it's not entirely clear what was being done with it. Is that true?
Yeah, I would say I'm not totally clear on exactly what was being done with it. Certainly, state leaders would be referencing, scientists and like the modeling results, especially like during, surges of new variants. It was, pretty clear that there's a need for some sort of change. But, it was a kind of chaotic time. And so it's hard to know exactly how what we were doing, influenced things. I'll say one exception to that. Early in 2020, we had thought that one of the priorities for the state might be identifying shifts in the reproductive number sooner, i.e., identifying surges, before, seeing ICU beds fill up. And so, inspired partly by data from New York City, we were looking into the possibility of there being some sort of sentinel surveillance program based on percent positivity among people presenting in labor and delivery. And so we did, we kind of showed how this might work, with sufficient enrollment. And the state did test this out. Unfortunately, only in the Chicago area could they find enough interested hospitals. But, what we realized all too late, and what might have been obvious to the state, was that, having a lead of several days wasn't necessarily that useful from a policy perspective.
Right.
So yeah, that was, I'd say, one area where there's potentially some mismatch. We thought we would be helpful, but we were influencing briefly like what the state was doing, but then it ended up not actually probably being as useful as we'd hoped.
And was it, from the way you're framing it, is that it was something to try, and it was almost like an open research question or engineering question at the time to find out, could we do this to actually inform what is happening earlier, right?
Yeah,
but
I'd say
it wasn't as successful as you wanted. And
So it wasn't so much of a research question. Like, it was pretty clear that this should work. So it was more of an engineering question. And so we were just, I think we were still uncertain about exactly how much of a lead this would provide.
Right.
And ultimately, as everyone knows, like, these hospitals were exceptionally strapped for resources of all kinds. And so this was presenting an additional reporting burden to them that ultimately we couldn't, mitigate very well. And we did also, I should say, originally conceived, this was not supposed to be only using people presenting for like labor and delivery, but also some of the state-supported testing centers. We thought that they could enroll individuals with symptom onset in the past 4 days, because as we know, many of the people who were seeking testing were, very late, post-infection. So we thought we could be tracking those like newly infected again and using that as an indicator of a leading indicator compared to hospitalizations of, transmission. And that ran into another problem, which is just that the testing sites, a lot of them were actually collecting paper records, so that wasn't really going to work. And there just wasn't the infrastructure in place. So yeah, so it was more of an engineering problem, but then also we clearly we didn't assess very well, and I don't know what the communication was like within the public health departments, within the government, about how much this would really matter, as far as pandemic.
Yeah. And you were working with the state of Illinois and not the city of Chicago, right? Were there any jurisdictional issues associated in that?
Yeah. So, and one of the groups was working with both the Chicago Department of Public Health and the state, but the city public health department was absolutely kind of setting its own guidelines after receiving some direction from the state. And that could have contributed to difference in enthusiasm, for instance, for the sentinel surveillance measure. But I'd say also an important feature of all of these early interactions was too that a lot of the local, especially the rural health departments, were also out of sync with the state. So there was there were really a lot of kind of moving pieces.
So some coordination issues there. Thank you. Thank you. All right, I'm going to move on to Amit. Amit, tell us a little bit about your experience interfacing with the Israeli government and some scenario modeling. You know, what situations was it helpful? When was it not?
So I guess a small comment about the previous. So I think, you know, the models were used in, like, for us in the strategic level, and that maybe initially, then they went down to the tactical and operational level. And each of them, you know, requires quite different things. And sometimes the success brought disasters. And so maybe our first, it was a very simple model that we developed like end of January, beginning of February, which was just taking an SIR with the Israeli population and simulating it for different levels of reproductive numbers. And we just wrote a small document showing, and this really simple thing had a very strong strategic effect, because somehow the manager of the Ministry of Health, the general manager, he saw it, and he later, he didn't even tell me later. I saw him in an interview saying that once he saw our projections, he understood we should go down to a lockdown, and then so like these really simple trajectory, a textbook kind of level, was successful. But he also leaked our document to the press, and there were really scary numbers of how many people might die. But the country went into a lockdown, so, you know, I think 50, 60 people died in this first tiny wave in March till June. And then we were hammered very hard by the press. So for me, it was something I really didn't expect. I thought, wow, we did a great job. But suddenly we were these people who were responsible for wasting billions of dollars on a lockdown. And
So basically, by using a simple SIR, regardless of the sophistication of the model, you were informing them of potential eventualities and the seriousness of the pathogen in question. Is that what was essentially communicated in this first report that instigated this lockdown or contributed to it?
So they even thought that a really small R of 1.1 or 1.2 would have catastrophic outcomes. So unless there's ways of mitigating it without lockdown, then it's going to be really bad. And initially it was, you know, we went into a lockdown, and Italy and Spain were in total catastrophe. And it was like, you know, it was a big feeling of we were able to make the right decisions fast.
So it's almost like you had a scoping exercise in this first model, and then they reacted off the scoping exercise, and then you had the counterfactual going on in Italy that suggested to them that they made the right call. Is that correct?
True, but then there was this backlash, which surprised me, that, you know, people were saying we were just overestimating, and first that people didn't understand that a lockdown is a good way to stop outbreak. Almost always works if people comply, and so everybody thought that, you know, our model is totally incompetent. We predicted 20,000 people dead, and there were 80. So how incompetent can you be, right? And really, you explain it to people, and you see they didn't get it. So that was like, I mean, the high people up in the decision making understood it, but at lower levels.
And as it's communicated to the public, there's no understanding that it was the actions that they had taken as this public health recourse and this policy had circumvented this or nipped it in the bud and avoided that outbreak.
Yeah.
Was yours the only model that they used in consideration before making this decision?
Yeah. And it was the simplest model I've ever done in my life.
And further down, did you, after this backlash, let's say in the media and by the public, did they continue to come to you for support? I mean, I know they did. So
yes. So we in parallel, we did two things. We worked very hard. So first, we grew from like basic 4 people working on it. We had at the peak around 80 people volunteering from different scientific communities in our group. So suddenly you have to find work for 80 people, which which can be challenging.
Yes.
And to me, the most important thing was to build the database. So the National Israeli Database was our main priority, as understanding that, you know, this toy model is good for step 1, but later we want to really do data-driven policy. And like I heard Sarah, and I said, wow, we were in Disneyland compared to her. We really had all daily data from all people tested in Israel, negative and positive. We would get our database, I think, updated 3 times a day. So it was almost online data. We worked very hard to get all hospital data from all the country. So we really worked our tail out building. I would say I mean, I think it could be done much better, but relative, when I look at other places, we had a very good database that later really helped us build a more complex model. But again, the thing was that this funny toy model was suddenly used for everything in the first 3 months. So I said that the government decided on 15 billion shekels, and I have to go and help them decide what we have to buy with this 15 billion shekels. I'm like, if I need to use 5 shekels, I call my wife. So I shouldn't bring her to the meeting.
So Amit, contrasting with what Sarah said, so Sarah talked about the additional burden providing data, collecting data is on the hospital and the public health system in an emergency. And certainly they're very strapped. What was it about, do you think, that was different in Israel that you were able to set up this detailed data collection? Was it that you were able to not intrude on the other services and work that these institutions needed to provide? Was there a slew of volunteers actually helping them do that? Or was it that case numbers were so low they had the time and availability to do it initially?
I think we convinced, I mean, it's not me, it's the team, we convinced them that this will help them make evidence-based decisions. Mm-hmm. And I don't remember what we told them, so I can't tell you the recipe. But I think so. From 2009, from the swine flu, we were thinking that we'll need a database, because in 2009 we were taking things by paper and putting them on laptops. Like that's what about 10 people with PhDs. That's what we did for weeks. And for me, that was that. I'm not doing that again. So, mm-hmm. So I was talking to the people that are in this, that we should do it. Then we had a polio outbreak like 2012 or 2013. And that's the first time we kind of tried to make something more organized. And I guess there was in the mental setting that they understood also that they want a good database, but they were willing to listen about how this should be done. And I think that was, if I reflect on our successes, that was probably the most important thing we've done, more than the modeling. the motivation was to do data-driven models, but I think it even helped more later in the statistical work on identifying the waning immunity and stuff like that. So that was the success. But if I reflect back to that original model, and as we went along, we learned more about what is scenario building, and so we did it very amateurly in many ways. Now, if I look today of what we did then, I would be really ashamed in the sense of how we explained it, how we built the scenarios. So I think it wasn't something. I'm not sure I even didn't use the horrible word of predictive model instead of scenarios, which is something that it's a big difference. And then how to communicate the uncertainty better, I think, is definitely something we should do better. So I really think that if we had done it better, we could have reached much better outcomes all along the pandemic. And it goes also to what you were talking about, other models. So of course, other models appeared, and this is again. So I'm not objective about it, but so there were not from the what I would call the main school of how you model an outbreak. Okay, so it was all these ad hoc methods of all kinds of strange regressions at best and stuff like that. And then they decided that they want, decided on 5 models, if I remember correctly. And they wanted to compare them on a weekly basis. And I was asked to do it. I was like, how am I going to work with these people that do things that I think part of them at least are wrong. So it was challenging in that sense. And I mean, probably they think what we were doing is wrong. So I'm saying it I think at least in this panel, we come from the same school, most of us. So
so we're a little biased in that regard.
Yeah.
If I could say, Amit, I'm hearing that, certainly it was a learning experience about how to model it, how to think about explaining it, how to communicate, and how to interface with public health agencies. And I think everybody was learning along the way, as invariably we would do in a situation, and felt at times like we were very underprepared. From that first model that you did that was very simple, what kind of late scenario modeling were you doing a year later for the Israeli government?
So vaccine priorities. Okay, I guess our second big success was we were asked about opening schools during the lockdown, and we found really by chance a bunch of families in this ultra-Orthodox community that everybody was swabbed. So they would enter these families and everybody was swabbed. So we built actually exactly the other side of it, a very heavily computational demanding model that was looking at susceptibility and infectivity of children versus older people, and it was like a really big effort. We had to do it in 5 days because they leaked it to the press that in 5 days we're going to give answers. Now, I would usually only think of how the model structure in 5 days at best. So we really didn't sleep a minute. We're working 40 people around the clock, but we were able to produce a report. And the funny thing, it started getting translated in Google Docs to English, and people asked us write the paper up. So like about half a year later, I think we wrote it up. So that was kind of, for me that was okay. Now we're also proud that we did something that required some good skills that 20 years of working and doing stuff like that were professional, and that was received well in the community. But then again, people were saying that that why, after we showed that children are half as susceptible as grown-ups, why our recommendation is not to open schools, and saying there is like a big gap between susceptibility and putting 40 kids in a small room. And I don't know how to go over this gap. And once again, we were starting to be criticized by the media. So I think most of our successes came, when I was patting my shoulder, I was starting to get criticized from all over. And when I was hitting myself from embarrassment or from mistakes, then you get compliments that you don't understand where they're coming from. So right. So the professional successes and failures and the feedbacks you get, even from the policymakers or the people around you, are very different than what you'd expect. And that was something that, so I think from June, July, I didn't care what people thought about me, wrote about me. I became totally indifferent, and that really helps. It was like just.
So after that first crash of criticism, you became very thick-skinned, and it helped enormously. But also there seems to be a real disconnect where if you get something right from people's perspective, then you get a lot of praise for it, even if you think it's undeserved or insignificant, and the opposite can happen as well. Is that fair?
Yeah. So I think the feedback system is not what I would have expected.
Right.
And then you see like models that are really horrible, at least in my perspective, becoming every day on the news, presenting it and explaining to the entire population, and you think that anybody who did 10 minutes of modeling would see it straight away. So it's different, and I think so. One thing I'm really bothered by is really, how do we make sure at least that the main dogmas get represented and get the right weights in the decision-making process? Because in all this chaos, it's, I think, if let's say I did a decent job, but me being there is maybe partially luck, not as partially luck and partially previous work and previous relationships with decision makers. I think you need a much better structure in the system, in the infrastructure, in order that it be much less chance and much more built on skill and being a professional.
Right, and I think that's a question we'll come back to. I'm going to turn to Jason right now, but the idea of who is spoken to, who are the people brought into the conversation, who are the modelers who are drawn in to ask questions, are they bringing the right tools to answer those questions, and how do we adjudicate that? Is that possible? I constantly feel if there's another pandemic in my life, I may be just totally the wrong person to approach on this, but maybe some people will, just because of my track record thus far. Maybe some people won't because of my track record thus far, but that doesn't necessarily mean I should be given that kind of credibility in the moment. And so who is brought into the room is a very interesting question. And then as more and more people stick their toes in or invited in or come in, how do you actually parse through all that information? I think we saw that in a big way. Jason, what's your perspective on this from the interface of modeling and public health, and how scenario modeling interfaces with it? You and I have talked about this, and I've given you my belief that there's a real difference between projections and predictions and scenario modeling, and that scenario modeling is really conditional probabilities. It's an if-then statement, and that there's a lot of uncertainty that derives from the assumptions that go into making those longer term projections, as it were. But scenario modeling also involves some of the stuff that Celia talked about, which are these very specific questions addressed at, well, how do we reopen schools? What's the best strategy for that? That's a very different form of it that puts suppositions in to try to address a complex question or answer an immediate public health question as opposed to a research question, let's say. Where do you sit on all this? What do you see happen? What was your experience over the course of the pandemic?
Yeah, I mean, that's a really wide-ranging question. So I'll try to do it in parts. So
you're a smart guy.
That's really kind. So, I think, first of all, there's one class of, if you'll even allow me to call them models, that hasn't come up yet that I think is worth kind of noting, which are these relatively simple kind of calculators where you get together the right set of people to define a range of scenarios that captures some important aspect of uncertainties, anticipated attack rates by age group, and your best assessment of infection fatality ratios, various things like this that can help define the scope and scale of a response. And especially early on, when there's incredibly limited information and people are trying to understand, in what bucket, if you will allow me to put that, to use that phrase, to place the evolving scenarios that they're witnessing and the kinds of things they're looking for that might change. I think that sort of work is useful. So I think one piece of kind of success that I think happened, there was really excellent collaboration between CDC and ASPR, the agency I used to support as a contractor, and the agency I work for now. So, that derives from, 10, 15 years of history experience working on a range of different pathogens and kind of collaborating around modeling. And so one of the first things we did do in early to mid-January was get together and start talking about, well, let's start scoping out what we think the space of the possible is, and what are the key assumptions we would need to make to support some of these kinds of high level, if you will, like risk assessment like activities. And at CFA, we sort of noted that this is one of the activities that we think is really important going forward, which is like early model informed thinking and qualitative risk assessment. And I think some aspect of scenario modeling fits into that. And there's an opportunity to provide either occasionally quantitative results, or at least the kind of qualitative conclusions that you can derive from quantitative scenario models. And that can help inform that early phase. So I think that's one kind of key thing that we did do.
Can I ask Jason, in the breakdown of that, is a lot of that analytics, or as opposed to scenario modeling? When you're talking about the quantification of sort of epidemiological characteristics, what's the split there in terms of that?
Well, I think some of it indeed can be estimated from real world data. I think others really early on, it's mostly by analogy, to say, our subject matter experts at this moment in time think that these are the kinds of analogies we're using to think about the problem. So we're going to be explicit and say, when we're talking about this, we're proceeding by analogy, and the other things where we can proceed from data, we do. Because I think that's this aspect of asking people to kind of lay out carefully what their assumptions are. All of us had internal decision-making models and ways that we were thinking about the future. And I do think there's a value in writing down carefully why you're thinking something about the future. What's the structure that leads to it? And it does come from often by analogy, or sometimes something that can be directly witnessed. So I think that kind of evolved. There were things that were done early on that would have been purely by analogy, and there are others that could have been estimated from data and eventually were. And so I think, say over the course of the first 1 to 3 months, I think that evolved quite a bit. So I think that's important, and being careful about what the range, why you think there's a certain range and what you're considering. I would say we were also pressed often to weigh in on sort of what we thought was most likely, which I think is a risky thing, but often a thing that decision makers are really interested in. And I'll come back to that in a second, because I think that's an important thing too, which is, having some kind of expert-driven informed assessment of what you think is either likely or most likely or more or less likely, or being able to speak about that. Or if all you can say is, I think it's in this range and I really don't know. I think all of those are informative statements. And I think it's important to capture those, make sure you evaluate them and change them over time as you learn new information. But having a process, a formal way of doing that and being clear about what you're doing, I think is one foundational thing that's helpful. I think a lot of the work that kind of person hours that even continue to today, my former team used a detailed agent-based model. It was adapted from an influenza simulator that's been used for a number of years to think about detailed interventions. And that was modified and applied to COVID-19 to produce, roughly speaking, monthly updates of scenario-based projections that would consider the outbreak evolution over the course of the next several months, typically would be the time frame. Sometimes there were special things that were created that had longer time horizons for specific reasons, and that usually had a greater diversity of scenarios underlying them. There would usually be many scenarios that went into the generation of one of those products to try to consider both scientific uncertainty as well as behavioral uncertainty. And I guess in addition, calibration uncertainty at times too. Mm-hmm. So there were, and then multiple even hypothetical or counterfactual scenarios that would go into it as well. So we could be assessing at any point in time dozens of different scenarios, and then down selecting to kind of think about what are the different sort of qualitative groups of output trajectories you could see in the future. How might behavioral responses or other policy changes relate to those, and create kind of a regularly updated informative product. And yeah, go ahead.
Who was when you were doing these simulations? Who was driving the questions? Was this from that CDC ASPR partnership that you were getting the specific questions you were trying to address in those simulations?
Yeah, I mean, it fluctuated over time, but in short, yes, that was always a part of it. There were multiple interagency working groups that kind of had different focal responsibility for the response over time. So I think that the specific customer shifted, if you will. Mm-hmm. I think that we were given a good amount of latitude, however, in terms of our scenario definition. It wasn't like people came to us and said, you must consider these specific scenarios. I think we were actually looked to try to frame what we thought the range of the possible was. And it was used for a number of different kinds of activities, thinking about, often I would say, longer range questions about procurement, so things related to testing and diagnostics, therapeutics and allocation, longer questions related to things like that. At times it was used as kind of policy communication advocacy by some members of the response too. So it kind of had a wide range of theoretical uses and practical uses. I think some things that were good about it is that, I already mentioned the collaboration. I think that was excellent. I think that we were able to provide advanced warning of the scope and scale of multiple waves that occurred over time. And, potentially most notably, the emergence of the Omicron variant was roughly maybe 3 or 4 days between when we had the first data that was shared from South Africa by some of the organizers, I think, of this meeting. In fact, and we were really grateful. We immediately used that to come up with scenarios that thought about degrees of immune escape and enhanced transmissibility, and had those novel variants kind of simulated, at least in some specific cases, and noted that what it meant was there was a very large wave coming in the United States in a matter of weeks. Probably, around the turn of the year at that time, and that the real major uncertainty was just how severe the particular risk of infection would be, and that needed to be determined really quickly. And there was maybe initial light evidence that perhaps it was reduced severity, but it wasn't clear at the time. So I think that's an example of where, in a really short time frame, under a week or something, we could go from the first data being available to having actionable simulations that people can look at and think about what that implies for us here. So I think that was excellent too. I think that the frameworks and tools that we built were fairly flexible, and we were able to adapt over time to add things like more careful, detailed immune history, multiple variants, the interaction between the timing of infection and vaccination when there was data available for that. Lots of different detailed assumptions that involved making structural changes to the model, and we were able to do that while maintaining production timelines even on a limited team. I think that was good. I think some things that were more challenging were that, I alluded to this first, which is that I think it's very difficult for many decision makers to understand some subtlety, like what you were talking about before, like what is a scenario, what is a projection, and what is a forecast. And I think it's common that, if you present, for example, a series of projections about different things that could happen in the future, one of the first questions you'll get is, well, which of these is most likely? Or in retrospect, if you provided a collection of projections and you're now 1 or 2 months down the road, people evaluate the accuracy of your projections as if it were a forecast, right? They're looking to see whether or not there was a trajectory among the ones that you provided that was the truth, or whether it was close enough or something like this. And sometimes that may be semi-appropriate, and other times that's not appropriate. And the distinction between when it is appropriate and not, I think, is an open question, very difficult to communicate. So I think that's one that's challenging. I think kind of on a more operational, technical level, the calibration process for the models I'm talking about, lengthy, requires a lot of manual intervention. In that way, it's not automated and completely reproducible, right? If you had substituted different analysts for the same task, you wouldn't necessarily get the same result. So analyst judgment plays into that. And I think that's something that's also hard to communicate. If something ends up being miscalibrated, is it because of a structural assumption, or was it an analyst error? And you can't really easily distinguish those things without doing a bunch of hypothetical counterfactuals that you will never have the time to do, and still would be questioned, I think. I think it was also challenging, this was alluded to before, the data environment varied greatly. So new data sources came online. The meaning of things within any given data source could also change over time. And now we're in a different data environment where many things that were used to calibrate these large scale models no longer exist. We relied on survey data that got to detailed questions about teleworking, data about school opening and closure or hybrid status, all of these kinds of detailed things that you have for a long period of time. As they recede in their availability, you have to radically alter potentially even the model you attempt to calibrate, because it could just be that there's now too much unobservable factors, too many of those to even calibrate it at all. I think the staff burden was also challenging. We went from a thing where we were trying to provide the best information we could, and then we're effectively asked to do it indefinitely. And I think that's another thing, which is something that CFA is really interested in making sure we have plans to address, which is, how can we have an appropriate staffing footprint so that if we're expected to produce, and we intend to produce scenario-based projections during future emergency responses, that we have the people that we need so that they're not exhausted, that you can rotate staff out, but that they're appropriately cross-trained, and that you've kind of exercised what that looks like, and have technology and tools that make it so that it's possible to bring in a new analyst and they can be engaging as quickly as possible with exactly the same workflow that other people are working on. So those are all things that we intend to do.
So Jason, when your experience is a little unique among the four of you here, and certainly myself included, in the sense that you were embedded within the government in some sense. You're at ASPR. When you were doing this modeling, were you using multiple different models? Were you comparing them to other models when you had some of these scenario-based questions? Were there entities outside yours, or were you sort of this go-to group that some maybe analogous to what Amit experienced, though he's an academic in his base, for the Israeli government?
Yeah, so I think depending on the phase of the response, we were sometimes the only thing. And then at other points in time, obviously, CDC did support, and NIH as well, the scenario modeling hub teams. We certainly made comparisons between the scenarios that were modeled there and our own. We provided feedback on some of the scenario assumptions at times when they were framing them. We made comparisons when it was appropriate to do so. We were obviously asked about lots of external models that were generated and what the differences were and why there were any. We did not have the resources internally to run multiple models. I think that's one of the things CFA wants to do differently. We intend to have our own, if you will, mini ensemble of internal federal models, which I think is important too, because you don't necessarily want to get completely boxed into a specific set of structural assumptions. I think that also connects back to the question I was raising before about how do you define your scenarios and what's the process for doing that. There is also some value to having minority opinions among what the appropriate scenario space is. So how do you avoid groupthink while still, there's value both in coalescing thoughts around a particular collection of assumptions, and there's also value in having these diversity of the diversity of opinion that can result when you say we're trying to hit this specific target. So I think balancing that is tricky too. But that's kind of was the landscape that it was, and that's where we're one of the changes we're trying to make going forward.
Yeah, within the CFA, and this idea of it being embedded and working with ASPR CDC, it seems that there's actually very different experiences among the four of you, because you were embedded and you were definitely stressed and strapped and stretched thin from what you say, and understaffed by the demands of what it was of the job and the continuance of those demands over time. But were you able to, completely drop everything and just focus on the pandemic? I imagine that was the all hands on deck that happened there for you. And I'm just going to contrast that with what you said, Celia, which is that, DoHMH doesn't sound like they have plans to build a modeling core per se, and that you're going to, in the next time, look to outside entities. And I can contrast that to what Amit experienced, where he's doing something very similar to what you did, it sounds like, Jason, except he's based at an academic institution, and he's leveraged and he's built out a group of up to 80 people doing a whole wealth of responsibilities that's really benefiting the government. And then Sarah, your experience from what you've told me was, after time, burnout really set in, and that there were too many other competing responsibilities for you to continue focusing on that. And I know from my own group, working with DoHMH and in other entities, that, a year into this, it was very clear that this was just not sustainable for us, with the level of expertise, the size of our groups, and how much we were burning out at the time. What is the optimal way to build in modeling at a modeling public health interface? And Jason, I'm going to start with you, because obviously that's what CFA is thinking about enormously, and you have a lot of ideas, but I do want to hear from the rest of the people on the panel on this.
Yeah, I'll say succinctly that in CFA, we have a specific function, our inform function, that is in our inform division, that is trying to play this interface role. So our thinking is that asking the same modelers that are producing the analysis to be the people also performing the liaison function is too challenging to do at scale. So we will have a dedicated team of people that are trying to both appropriately contextualize modeling results. So there'll be people there who understand modeling, but also people who are experts in communication. And they'll work with folks in the predict division, so my division that has all the data scientists and modelers, but they'll be trying to translate them into a decision-making context, and also kind of performing the opposite direction of flow, which is figuring out what the decision maker questions are and making sure that the work that we're doing is addressing them in a time frame that's useful. And they, over time, as they expand, do intend to have liaisons with state and tribal and territorial and local public health organizations to think about how we can even project capability, create tools that are open source, test deploying them, potentially even provide cloud-based computing where you would be able to have your sort of secure enclave. You could upload data and work with it. You could have external partners that are provisioned accounts, and they wouldn't have to give their data over to CDC. They could kind of have it in their own virtual kind of private cloud, but they would have access to exactly the same kind of tools that other people would have. So all of those, I think, are part of the kind of future vision. Forgive me, an ambulance is going by. I hope that wasn't too horrible. So I think those are all parts of the ways that we're thinking about how we can provide supporting services and interact there.
And what I heard earlier, you're also thinking about, how do we stand this up? If in peacetime we're condensed down to this level, how do we ramp it up so we have that expertise in place and don't burn the people out? Celia, is this the type of thing that you've been on top of and that you want to interface with? I mean, is this the type of model that fits with your perspective from your public health agency?
Yeah, and I'll also just note that New York City is not like a typical local health department for the US. We have a lot of differences from a lot more resources than a lot of my colleagues that have at other state localities and even states. So love that CDC is pursuing this, and we're certainly excited about partnering with CDC on this kind of work. And as you know, I think New York City has a ton of data, a lot of surveillance data. And so having those agreements in place ahead of time is like really, really key to being able to ramp things up quickly. So that's certainly something we see as an important part of our preparedness phase of things. it would be very difficult for us as a local health department with all the many other responsibilities that we have as a local health department to additionally build new capabilities to have the level of modeling expertise that academic centers or the CFA have just kind of around. I would love if we were funded to be able to do that, but I don't foresee that happening.
Understood. Sarah, what's your perspective on this as a means of operationalizing things? Go ahead.
Yeah, so thinking back to Jason's comment about ensemble modeling, I mean, that was one of the strengths I thought in Illinois, was that we did have that structural uncertainty represented in the models and in what we were communicating to policymakers every week. Each group, was presenting their 95%, credible confidence interval, and we had to explain why our results predicted more excess ICU usage than Northwestern's, for instance. So that was intellectually very satisfying. I think it probably helped with our credibility a little bit, that we were constantly trying to reconcile our different assumptions. So I would definitely do that sort of thing going forward. But my main thought, after hearing your question, Jeff, is that I think, modeling was kind of overpowered in some ways in Illinois in the pandemic. And the real challenge, in my view, with scenario modeling is not so much the analytic capacity of infectious disease modelers, in the country, speaking very generally there, obviously, but really the problem is the quality of the different data streams. And we just did not have, in my view, the infrastructure in place for really good, rapid, analyses of what was happening in the state. And so if I had the resources, I would probably not be allocating it toward more infectious disease modelers. Probably shouldn't say that, but I'd be putting it more toward that basic public health, not so basic, but public health infrastructure. We even, we're thinking about whether we could second somebody from the group, and this really wasn't practical, but to help integrate different data streams that were perennially siloed, in the first year of the pandemic, and which often didn't agree with each other.
Well, let me ask you this in that sense, though. You're obviously a modeler, and you're not advocating to get rid of it, but you're just saying that in order to actually work a system well, it needs to be a data-driven modeling exercise as much as possible. I think Jason's point early on was that early on you have to proceed by analogy, by what you know, and as the data and evidence build out, you would use that. But it sounds like one of your big concerns is how data is actually collected and reconciled in this country, which is an endless problem that could be an entire other workshop and probably has been 4 times over, for all I know.
But I should speak to that very briefly. Early in the pandemic was a really good example where the United States obviously could have had, if we had stood up testing faster, much higher quality data, and it would have saved us a lot of modeling energy. And things could have been really different. We didn't have to go so much by analogy. So I still think that the data problem is really fundamental to just how we think about what the modeling challenges are.
Yeah, absolutely. And you have to go where the data are. I mean, I can say from my own perspective, we did this initial projection for the United States in mid-March, and it wound up on the front page of the New York Times. Well, why did it wind up on the front page of the New York Times? Because we were doing work on it, and we noticed the New York Times had county level data from everyone, because they had actually employed a team of people before Hopkins stood up or anybody else stood up data on this. And they were paying people to figure out and call up all the health agencies and compile this stuff. And I just approached them and said, can we use these data? And they said, yeah, but we want to be able to publish what you do. And I said, fine, if you want to. And that was me just going where I could find information to tell me about what was going on. At the same time, Amit, you said something very similar here. You said that the big thing for you was accumulating data. And it has allowed you to do these much more sophisticated analyses on waning immunity that are, not necessarily model driven even, to understand what's going on. In that context, is this something that can be perpetuated? We often see that, when there is a disaster, a lot of resources are moved into that space, but then another disaster in another area and other priorities come and funding goes away. What are you doing in Israel, if anything, to try to maintain this level of surveillance and vigilance to keep on top of infectious disease threats? Do you see it dropping off? Is it something that can perpetuate?
So I guess I took your invitation to speak here mainly because this is what I'm troubled. So I'm not sure next time we will. I think we should be much better, but I'm not sure even we'll be as good as we were before. So that's exactly what I think. We need to think of how to make sure that the things that worked will at least work at least as good and hopefully better, and the things that did not work well are fixed. And at least for me in Israel, I mean, I'm going to be unpopular for saying it. I don't see enough work in thinking and making sure that we will do better next time. I wanted to add something about the data. So we had relatively good data, but I think it's really important to understand that models are limited. Okay, it's not that if we'll have this amazing data, we'll be able to do everything. And I think the morning session was on behavior. So we're not going to be able to predict the human behavior and even less the government behavior. As somebody who sat in a number of cabinet meetings, I mean, I think nobody can predict how politicians think and make decisions. And again, that's what I was speaking in the beginning. I mean, you're not going to be able to predict 4, 6, 7 weeks ahead because there will be changes in the policies and the behavior. So we, as modelers, we have to think more what's more realistic, what should be modeled and what should be not. Okay, so like I mean, it's again, scenario models give you at least the risk and stuff like that. So they have a value, but we really need to use models in a better way, in understanding their advantages, disadvantages, what they can do and what they cannot do. I mean, I can tell you about myself that I was doing things that in retrospective, I think they're stupid. You know, they were a waste of time. And I'm guessing all of us can say the same, right? I mean, I know I'm more stupid than the average, but I'm sure everybody did these mistakes of doing things that are not really helpful.
Well, you know, in some sense, I'm hearing a lot from you, Amit, that it's sort of a pragmatic approach. And maybe you could take that pragmatism a little further, which is that data is not going to solve everything. Superior modeling is not going to solve everything. Getting the right people in the room is not going to solve everything, and getting communications settled down, it's not going to. But all of these can be improved. I mean, Jason, when I hear you describe what the things you're trying to accomplish and how you're structuring the CFA, I'm very encouraged by it. But at the same time, you know, I now want to ask you, well, what are you going to do about the data? How are you thinking about collections of data? And that's a larger question that may be well outside the purview of the CFA. But how do we move surveillance to a more advanced state or a position where it can be stood up? And Celia, maybe you have ways of addressing that. I think there's pragmatically.
This is Madhavi. I just want to interject you just for 10 seconds to just remind you that there are questions in the chat.
I will get there.
Ready. Yeah, whenever you're ready, I just want to let you know that there are some there.
Thank you, Madhav. Thanks. So in this context of sort of looking at it pragmatically, under the sense that there's a need for modeling, and in order to do this in the next situation, we want to stand things up better, but there's a reality that the resources may wane and we're going to have to build things out. Is there, I'm hearing different priorities here. Sarah, I heard you say it's got to be data. I heard Amit say that, you know, there's a limit to what the data can bring. I'm not so sure whether I'm just, you know, pontificating here or really going to pose a question, but is it come down to resources at this question? Is it just a matter of attention and resources? Celia, what do you think here?
Well, yeah, I mean, I don't want to speak for CDC, but there's been investments in data modernization for state and local governments that are coming through CDC, some funded from, COVID related funding, but some of which is expected to continue. And that's really wonderful. We're able to advance a lot of projects that I know have been high priority for us within the city health department. We already have fairly robust surveillance and good data on like epi and surveillance side compared to a lot of local health departments. That said, I think in the US generally, there's a real gap when it comes to clinical data and like hospital operations type of data. And that is, related to how our the care delivery system is set up. And it's a real huge challenge. Prior to working in disease control, I worked in healthcare preparedness here at the health department for a number of years. And so I'm really familiar with all of the data collection challenges related to hospitals. And then taking it up a level, and for what Jason needs to do, I'm curious to actually hear his thoughts about this. The way that CDC gets data from state and local it also has a lot of challenges, and there's, regulatory pieces of it as well. So the type of data that we're able to use at a local level is very different from the type of data that CDC has access to. And so that's another wrinkle to the set of problems that you just described.
Yeah, I mean, I think rightfully data is important, but I don't think it's an either or. I think we are going to invest probably dollars wise and effort wise more on the data side than on the modeling and analytics side, but I don't think we should neglect the enduring capability that is needed in-house. And I think that, the academic community, I think, is a really important partner here. Like, I think that it's excellent that we have such a breadth of capability distributed across all. I think we've asked academics to do a lot of things in a way that I don't know is completely aligned with the incentives or goals of academic research. And I think that looking to academics to be our operational arm, our response arm, and outsourcing that work and asking them to do it on the timeframes that are actually needed for decision making, I think is difficult. So I think looking to internal federal capabilities in addition to academic capabilities, I think, is important, but absolutely data is critical. We have, I think there's several different things. So first of all, there's the Data Modernization Initiative, which is this large effort to try to make the pipelines of data that flow from state and local data sources into CDC much more efficient and modern. I think that will take time to realize, but it is like one of our sister efforts that is kind of on our critical path to success, and I really want to see that succeed. So I think that's part of it. I think for certain key questions, if you want to do a more limited kind of epi study and you want to estimate some parameter of interest, for example, during the Omicron surge, we worked with Kaiser Permanente of Southern California and some people from Berkeley to come up with the first US estimates of the relative severity of Omicron infection as compared to Delta infection. And that was done through a kind of convenient arrangement that happened to be there in place at the time. We want to make those kinds of arrangements more formal, where we will intentionally be able to ask questions, not necessarily ask payer providers to provide data to us, but actually maybe be able to go to them and say, we want to estimate this specific quantity. We think you may have the data that would do that, and have some arrangement to figure out how you might have that formalized. So I think having kind of more targeted questions for estimating parameters, there may be opportunities to engage other sectors to get at that without having to have formal data sharing. I think there are theoretical technologies at bear too that could be brought to bear. There are various kinds of privacy preserving and encryption technologies that can allow you to do distributed federated learning for, again, certain classes of problems. It's not the general class of problems that we're talking about here today, but again, for parameter estimation, there might be opportunities in that region. I guess I'm a little more optimistic. I think we have a lot of challenges. I think that persistent resources and support are going to be very important, but I do think we can make measured improvements on this if we can keep the focus on not letting this end up in another cycle of neglect where we wait for another 50 or 100 years for something truly catastrophic to happen again, to remind us of why it was so important to pre-position these capabilities and exercise them.
Fantastic. All right, I am going to turn to questions now. The first question is from Ayush Chopra. He asks, what kind of models do you use? ODEs, ABMs, black box forecasting models? Sarah, I'll start with you. I think you've alluded to it, but you just want to briefly say what kind of models you've employed?
Yeah, so my memory of the first couple of weeks is a little fuzzy. We probably did all sorts of things very quickly, and I know we did not share all of the projections from those models because we were too skeptical of them. But what we were mostly working with was a dynamical compartmental model that included multiple stages within the hospital. And eventually we were fitting that using POMP to data that we had access to, again, from a couple of different streams. But a lot of what we spent our time on was, again, actually just trying to reconcile those different numbers from different hospitals that did not always make sense and could be reported with incredible lag sometimes.
Amit, you when you moved on from that at first SIR, what kind of models did you grow into?
So we use age of infection, discrete time models that are relatively easy. You could put like the generation time, and we were working really hard on estimating the generation time by triplets of person who infected a person who infected a person, and then you could get some estimates of serial intervals, and then you could go, you can expand it to age groups and some spatial stuff. We had individual-based model, which was a huge effort. If you ask me, was a big waste of time. I mean, it's so hard to get really parameterize these monsters that in the end, I found them, if you want to do data-driven things, there is a limit of what details you could do. And maybe they can be used for certain local questions, but on a national level, the thought that you'll have a model of 9 million people moving and meeting, and I don't think we know how to parameterize such models. I'm not sure we'll ever be able, because of all the behavioral changes and the policy changes. So that's one thing I was trying to hint that, we need to know the limitations of what could be done in real time. So that's another one we had. We were trying to do almost there were statisticians working on these Markov models of hospitalizations and moving between different, these are kind of state models within hospitals.
So it sounds like a broad diversity of models. You had a whole range, really.
Yeah, so any idea of a modeling, we would find some people that's their expertise and tell them, are you willing to join and do it? If, it were people that we thought are capable and good and people who are understanding that the collaboration is not about writing papers, but about making decisions, which this is another important thing I think that, has to be put on the table. In a scenario like that, you're not going to be thinking about papers. You need to think about how to make the right decisions, or you're not going to make the decisions. You're going to maybe support the decision making.
And that's one of the difficulties of employing academics, because the currency of academia is going to be publications, it's going to be grants, and those are the things that actually are capitalized on for stature and promotion within it. And I think that's something that Jason alluded to also when he's talking about having an operational center, that you need to step out of this where it's the interests are going to be that interface and operational use and communication and support of public health decision making in a real way. Jason, you mentioned ABMs, and I believe you said that was really the focus of what you did at Asper. Is that correct?
I would say for the bulk of the time, in terms of time effort, yes. Towards the kind of tail end of projections, and I think what people are using today is a kind of county scale stochastic metapopulation model that's age structured. We also have a library for more typical ODE compartmental models that were used really early on for other things, as well as some of the like ACIP analyses. So some of those are publicly available tools. So there was more for the interest of having something simple that you could use to explain one or more policies. But yeah, in terms of person effort, it was mostly a an ABM census tract scale. It, like the metapopulation model, has usual nodes of interaction in the home, school, workplace, and general community, and has lots of different interventions. I definitely take Amit's point that you have to be careful about the employment of ABMs. I think we were able to do a reasonable job calibrating them. I think that I definitely agree. You have to be very thoughtful about just how structured you are. And I think there are ways to produce slightly more simple ABMs that have some additional emergent structural features that are helpful when you are trying to consider specific interventions, say within a home, or the interaction between school and workplace interventions and so forth that can't be captured by other models. But it's not always the case that it's necessary, and agree that there are limitations on the calibration.
Okay. Next question we have from Kat Shea is, how did your scenario modeling and decisions consider uncertainty, particularly in the early stages of the pandemic? Celia, how did you think about the uncertainty across the models, if you can weigh back in across to what you were thinking back then?
Well, it depends a little bit on like what question we were trying to answer with the models at the time, because how important that uncertainty is made a big difference in terms of, if I'm counting the number of hospital beds I expect I need, that's like a really different type of uncertainty than trying to understand what's the relative impact of different types of interventions or different timing of interventions. So one of the big challenges was to kind of take the different models that we're looking at and translate that into a planning assumption for what's going forward. Because I wouldn't want to say, okay, the expectation is we're going to have this many cases, need this many hospitalizations. We could say, listen, we have different types of models with different assumptions that are giving us a range that's, I don't know, we'll need 30,000 to 140,000 hospital beds. It's a really big range. Somebody has to make a judgment call about what is our planning assumption, what are we going to plan for over the next 4 weeks, and then we adjust as we get more information. How and who gets to weigh in on that judgment call is like the real question, and it has to do with how the different response structures are set up at the local, state, and federal levels.
Excellent. Jason, what was your experience with that?
Yeah, so I alluded to that before. I mean, especially when developing our scenario product, we would have a number of different scientific and behavioral uncertainty dimensions to the assessment. So it could be uncertainties about timelines and whether or not there was waning immunity, either from infection-acquired immunity or vaccination-induced immunity, the effectiveness of vaccines, the likelihood of the reimposition of behavioral interventions in the face of future waves that might occur, the characteristics of individual variants, including its transmissibility, degree of immune escape in relationship to previous infection or vaccination. It changes to the generation interval was another one that later on became part of it. So we usually would persist a number of different scenarios like that, try to calibrate a handful of those, and then project an additional, even larger diversity of scenarios into the future when considering typically responsive behavioral interventions or uptake of a booster or other vaccination course or something. So we usually had dozens of different scenarios that went into the construction of any one of those products.
So it sounds, could you break it down as the uncertainty derives not so much from perhaps not knowing what the scientific values or the inferred quantities that are guiding it, but what are the range of processes or effects that may materialize over time, be that something emerging, being some kind of intervention. And that's also versus the structural assumptions that go into any model. By working with one model as opposed to 100 different models, you have another set of uncertainty. So you were really working in that space of what
the first two and not right. The first two, and yes, as was noted before. So we were primarily using one model for all of this work. So that's one place where we want to make improvements at CFA, and that's tied to having the resources to do that carefully. But yes, we did try to consider the first two halves of that.
All right, I'm going to go to the next question. It says, in hindsight, how did these uses pan out of scenario modeling? Asked in New York, but happy to hear from others, not just in terms of were the right answers right, but how were the insights helpful in making decisions and informative? This is from Carl Pearson. So were there any moments where you found the modeling particularly helpful and other moments where you found it particularly wasn't? Amit, you've talked about that a bit, but I'll start with Celia here.
Yeah. Yeah, so I mean, I will say like the simpler, the better for things that have to be communicated to the public or to decision makers. Like I will definitely sacrifice precision for something that's easier to explain. So that's one thing, just as the person who's not often in the room with the mayor making the decision, but trying to prepare a commissioner or someone else to be in that role and being the translator between our, subject matter experts on infectious disease epidemiology and the leadership level. I definitely appreciate things that are simple. I think for myself, I found it the most useful to really understand what are some of the dynamics around the different interventions that we were considering. So like to understand one thing is going to change the output a lot, something else might change it a little bit less, and that's not always intuitive, how those things were going to play out. And I found that really helpful, just informing my own understanding of how things were working in order to help our leadership make better decisions about what to do next. So that's how I found it helpful. One thing that I found repeatedly true throughout the response is that, the modeling that our academic partners did, as expert as it was, it could give some insight into different options. It could give some insight into what's happening with the virus, what's happening with our population, but it can't really tell us what our values are. And that's what we really need for decision making. And so, I was looking at models predicting this many hospitalizations under these conditions, this many deaths under these conditions, but that doesn't tell me what number of hospitalizations or deaths is acceptable. And that's really, where the decision-making has to come from. And I think it was also often a little bit unclear sometimes to the health department, sometimes to the modelers about what the sort of like societal values were at any given point of time during the pandemic.
Yeah, very good point. Michael Lee asks, is it possible to create, it is possible to create any model and model anything after nearly 3 years of COVID, and many years of disease modeling before that. Is it possible to generalize a narrow collection of scenarios, questions of interest we can work on to prep or improve on? This might be extremely useful for the future or improve the state of the art of disease modeling or other pathogens. Do you consider that there is a narrowed sense of questions that we can work on? We've danced around priorities, but this seems to be getting a little more specific as to, are there times when a model is inappropriate for a particular scenario? I've seen this happen a lot, where would be better to call it out and say, no, you should sit this model out, this exercise. It's not appropriately constructed for delving into this question. Maybe that's one way of looking at it. More broadly, maybe flipping it, saying, are there critical questions that we need to focus on here? I think that seems more of a broad question. What do you take on this? Amit.
Well, so I was talking about it a little bit earlier. I think there are things the models will not do well, okay? And give you one of the big failures. Last year, how many COVID and how many flu cases will there be in the winter? I mean, really, a question models cannot answer. At least, not now. I don't know if in the future they will. So I think we should really understand what models are good for what, and then what are the questions that are important, like. So one thing is, let's say you need to do a lockdown and you don't want to pass the threshold of the hospital ICU capacities. So one thing you have to understand is the time scale that it takes about, I think, 3 weeks between the number of infectives that you have now until they transfer to become in the hospital. So if you're going to need to make the decision, you need to know that a few weeks in advance, because if you're going to do it once you're very close to the threshold, you're going to go way off. Jeff, your famous work on if you would have done the lockdown 2 weeks earlier or 2 weeks later, and the catastrophe differences, and so stuff like that. And there are a lot to something that when we talked, the 5 of us yesterday, you called it, I think, mental modeling. So I think one of the most important things that works with decision makers is that from using models for over 20 years, you know pretty much in your head, you have quite a good intuition about what's possible and what not. That allows you to speak with confidence in the room. So, you know, mistake number one is going into a room not being sure of what you want to tell them, because all this uncertainty, that as scientists, it's really important for us to measure the uncertainty. When you go into the room with the decisions, you have to know that there is an uncertainty. You have to explain to them that there is uncertainty, but you have to be certain with what policies you're going to recommend. If not, it's not. In the end, they're going to choose something that is they don't have. At least you have more understanding of that than the decision makers, and that's something that. So I know I'm a little bit doing something that is a little bit cutting the tree I'm sitting on. That I'm skeptical about what the models can do. And that, like I can, again, about uncertainty. So I've been called up by very famous statisticians telling me, Amit, you know better how to quantify uncertainty. Why don't you do everything in the model? And I told them, look, you have to put a limit into the uncertainties you put in the models, because they're on scales that are unrelevant, okay? If these behavioral things can change your scenarios in 2-3 orders of magnitude, I don't care about something that changes the predictions in 10-20%. And so I don't remember the question, sorry.
I think it's good. I want to go to Sarah. Sarah, you were the one I was going to go to next. It was good.
Sorry, I mean. So one thing that I've been reflecting on lately, the question is about what kinds of general improvements could we make to models now to be better prepared.
Well, I think it's saying you can build any model and model anything. Can we narrow down either the types of questions or the types of models that you would bring to bear on questions in infectious disease epidemiology?
Yeah, so I think there is a need for better modeling transmission of respiratory pathogens. We've invested a ton into identifying who's making contact with whom through these social diaries, and could arguably invest a lot more in that, but we all know that we can parameterize our matrices if we want to with data from different studies. We also know that there's a very over-dispersed offspring distribution, that few people are responsible for a lot of transmission, and there's enormous variability. I don't know how many people here like to measure carbon dioxide now when they walk around, but there's enormous variability in spaces where people hang out and transmit to each other. And so I'm talking about in that transmission potential, the CO2 varies a lot. And this to me seems like the most basic thing to be working on, actually. It's just understanding where we have these opportunities for, I don't know if you want to call them super spreading events exactly, but just dramatically higher transmission. And so as we all know, there was a lot of investment into general agent-based models that could be used, for all kinds of pandemic scenarios. And a lot of those models, they're quite detailed about where people go, but I think we're missing that really critical element of the environment. And then other things people have mentioned here, which is obviously like immunity is more complicated than most of us like to start out assuming, and behavior is a real struggle to model. But it seems like the propensity for aerosol transmission is kind of low-hanging fruit, is something to be parameterized.
But it's very difficult to observe. I mean, and it's very difficult from my perspective to get people interested in those microscale processes. It's been something that I've noted for a long time, at least personally. All right, Madav, I think we're going to give you the last question. You had two of them here. You said, based on experience and advances in data collection and modeling, one desires faster and better outcomes from models. Stock trading is a great example. How do we address this for infectious disease modeling? Jason.
Yeah, I mean, I think I hinted at this. So it connects somewhat to the question that was just asked before, I think, which is that we do, my experience, and I think a lot of other people who had to work on previous pandemic responses, we do get asked the same or similar kinds of questions over and over again in different contexts. And so it is possible to identify those common questions and try to pre-position tools and models that are adept at answering them, exercise using them, and set performance objectives and really treat it like an engineering problem. So I think it is possible to take that engineering-driven approach to try to create, at least for your operational center, ways to do this. I do think there will be additional work that needs to happen in the kind of research and development space. And I think that's another thing CFA wants to do through our innovation function. And it will get at some of the questions that I think, Sarah was talking about before, which I think are incredibly important. People do build incredibly detailed agent-based models and then make interesting, simplifying assumptions about what it means to be in a place where there's 100 people versus 1,000 versus 10. And I think the typical assumption is wrong. And I think and it doesn't vary by the settings in the ways that we think they are quite likely to do so. So I think all of those things are worth investigating, but I think we can separate two different sets of questions. One is, how do we make better models over a longer term? And the other is, how do we take the best technologies and capabilities we know of today and apply them to decision problems in a defensible manner and exercise making that an operational capability? So I think it's those two halves working together.
Fantastic. And the second question was, we did not discuss as much about coordination between various levels of policymakers. This includes methods for data exchange and concerns. Are there any reflections or discussion points on that? Celia, did you find that the coordination maybe still within just DoHMH? Do you feel that there was need for better data exchange and communication within the agency in ways? I'm not asking you to this to make you a confessional here on a YouTube live stream about DoHMH, but are there things that you would see could be improved? Let's put it that way.
I mean, yes, and the question itself about the different, levels of, policymakers also kind of, a question near and dear to my heart as a federal assignee to a local health department in a state with a lot of state and jurisdictional issues. So, yeah, I mean, so, every emergency we can always coordinate better, and information sharing is like the heart of that, especially for public health emergencies, more so even than other kinds of emergencies, I think. So, yeah, this is something we're always striving to improve. And I mean, for data exchange, it came up about the data modernization initiative, and we're putting a lot of those resources towards improving that kind of like data systems coordination within our own agency to improve that for New York City. But I think even our information sharing with our academic partners, like we definitely need to think about how to design our data use agreements, our data governance policies to make some of this happen a little bit more easily when it needs to happen quickly for a public health emergency. And if I may, I just wanted to also pick up on a little bit the discussion earlier about like how to improve models generally, because, one of the things that was a struggle for some of the work that we were trying to do during the pandemic was how to center race equity and health equity outcomes in our response. And it was a little bit difficult to do that in some of the modeling work, a lot because of issues relating to like what kind of data was available that was going into the model. So I just wanted to flag that for areas for future development.
Excellent. All right. Well, I'm going to thank the four panelists for joining us here today. Really appreciate your time and your input, and also your contributions during the pandemic. I know you're probably all still recovering from the exhaustion of the last 3 years in some way, and appreciate all the efforts that you've put there. It would be great if you could stay connected with this issue, and thank you again for your time. I don't know quite why I said what I just said there, but thank you for your time today, and I think I'm going to close the session at this point.
Yeah, if I could take just 10 seconds to
please.
Thank you for being such a gracious host and moderator. Really appreciate it. And also all the panelists. This is absolutely a brilliant session. There's a lot of interest in this topic, and these questions are open-ended, something all of us have struggled. So I really appreciate you taking the time and talking about it, because that's the only way we can pass this information to various agencies. And I really like the broad perspective. But thanks again. We'll meet again tomorrow. This is day one that concludes today, but day two, the same times tomorrow. I look forward to meeting you all, and hopefully you all will enjoy the second part of this panel as well. Thanks again, everyone.
Hey guys, thank you so much. Is it just us on here?